box. So let's move on to special population. I assume, Steve, that's you?
Yep. Are you all seeing my screen?
Yes, we are.
All right. I want to thank our terrific leadership team to start with. Olga Harin, Panos Georgopoulos, Johannes Hasshaver, and Rusty Reeves. The addition, which happened this year, of of Rusty, a psychiatrist who leads the mental health component of the prison health system operated for the state by University Behavioral Health Care, is really a nice step towards developing the justice-involved populations as a special population. And we've had a lot of activity lately around that, and several organizations reaching out to us because there's a COVID, a new COVID thing happening, which is a very quick release under new state legislation of about 20% of the state prison population. And there's a lot of concern in the legislature and others about whether the reentry system is prepared for that. So we were asked to kind of jump in and try to do some quick evaluation of what's happening. And that's brought us to partnerships. In the end, working not so much directly with the Department of Corrections because it's a slow process, but working with Volunteers of America and with the Bloomberg Opioid Initiative and Hopkins to get some quick turnaround response for what's happening with the release of all these individuals into an overstretched reentry system with a drug treatment system that is overextended. So I think this area of the justice-involved population has been one of particular growth in recent months. So to remind everybody, we perform a number of service roles across the NJACS and the university. Frank mentioned the data set development, which is complementary to what is being done with the clinical research data warehouse. These are large CMS and state data sets that at the moment we don't actually have a permission under federal rules for them to be managed under the cloud. And we've developed this whole parallel system. We basically have data on about half of the people in the United States through having Medicare, Medicaid, national Medicaid policies, data sets. A lot of work goes into figuring out how to update those, link them. And I'll talk in a minute about a data set enhancement opportunity that's now being used sort of across a lot of clinical areas with Medicare data, linking them to community data. So we do that. These activities are all synergistic. The scholar mentoring, and many of the scholars, not all, are using the large data sets. The navigation consultations, which have increased on the premise here is that we have some unique resources at Rutgers to address heterogeneity in special populations through having these very large population health databases that are national in scope as well as state in scope, and that there's a service function needed of support to help people understand what can be done with them, to incorporate them into their own studies, as well as the development. So we have the navigation consultations, what kind of data are available, how could we use them, what kind of measures can be constructed. So starting with the data set development, which is sort of one of our core services, where we serve the development and expansion of large data set research by facilitating access to these enormous databases. We've got a couple of hundred terabytes that have been added to the platform that serves these. We're doing yet another round of revising all of the data management plans to meet CMS standards for their identifiable data. It was very unusual. Very few facilities have 100% Medicaid, for example, from CMS. And we have about what amounts to essentially 50% of Medicare beneficiaries with Part D, all of their claims histories. So the progress on this lately, we have a very unique data set that had to be purchased separately, which is, there was a special project that was done to merge all of the Medicare data for 2008 and 2016 by CMS to the National Death Index. This is an extraordinary resource for mortality outcomes across populations, across clinical areas. So we raised the support to purchase those data at the cost of $160,000. And we now have up and running the 100% Medicare data set for those years with 100% match to the National Death Index. Those data are being used in a pilot study by Stephanie Shao and on her K. So mentoring and supporting, consulting with Stephanie was an example at the School of Public Health, was an example of one of our consultations. Her K award that we worked with on this is now being brought forward next month for funding. So we built that data set, and we're just starting to really develop documentation for it and to start using it. We updated national Medicaid data through 2018. We developed a number of proposals that we pitched to the state of New Jersey to enhance the Medicaid, the New Jersey Medicaid data set that they provide to Rutgers with a monthly feed. And the components that we propose to add, each one of these requires negotiations with the top leadership of Medicaid. So we propose to add mortality, a mortality link, and to add information on who are the prescribers in the pharmacy data, which is something that they have and we don't have. And those were approved in concept. So we're slowly moving forward to getting those data at Rutgers. There's quite a number of projects at Rutgers that use the New Jersey Medicaid data set. This part here I'm really excited about, which is that and it goes right to some of the opportunities that we talked about with Ray from the beginning, to enhance these claims data sets with information on community exposures, community resources. So we had a whole project to identify candidate. There's thousands of them, and you have to do some selection based on research priorities. We ultimately selected and linked more than 700 community variables representing community health resources, community environmental exposures, economic changes, and we worked with the Harvard Public Health Disparities Geocoding Project to pull in some of those variables, along with Area Health Resources File and other sources. We now have up and running a linked data set. And interestingly, one of our TL1 trainees, Jennifer Miles, was instrumental in, she worked together with our data analysts. So she didn't do the heavy coding, but she did the conceptual finding the sources, and she'll be presenting a workshop for all of those who are interested on using this linked data set. We continue to work on updating the national Medicaid data set. We acquired and integrated 2013. This is something that due to a transition in the data sources that CMS has been behind on, but they've now released through 2018. And we're in the process of acquiring those data, which we should have by mid-year next year. This is 100% of Medicaid, all 50 states for the country. Peter Treitler and our other team members, Sharon, Jen, and Natalia, have worked to develop the Department of Health IRB to link Department of Corrections data, because Rutgers is the provider of the prison health services. So we have EMR data on all the prisoners that we're linking to the health department data on hospitalizations, on mortality. There's a big phenomenon of people dying of opioid overdose soon after they're released. And we lose a few every month. And we're trying to figure out how to understand and reduce that, working with the state Division of Mental Health and Addiction Services. Scholar mentoring is very important to what we're doing. You've heard Kiana Brown's name mentioned a couple of times. One of our outstanding trainees who was attracted by the research resources that we've put together and the mentoring. An additional contribution that Kiana has made, which hasn't been mentioned, was teaming up with Mark Einstein and others on the UO1 application. So she's a co-investigator in that. This is the Well Mama Action Hub. She's also developing an R1 using linked Medicare data for perinatal maternal morbidity and mortality in the Medicare disability population, which is a huge advantage that we have. We have these data set on an understudied population, which is all those people who have Medicare, not based on age, but based on disability. Very high mental health burden, substance use burden, multimorbidity. Stephanie, as I mentioned, is working in the HIV area, got 3rd percentile on her K award that we worked together on, which is now being brought together for funding. So we're in the middle of responding to just a few comments that were on her summary statement. Jennifer Miles is another star who was attracted by the resources and mentoring that we have. Now a TL1 fellow and just going to be a tremendous contributor to all of these. Amasika Nyako, who is fantastic, infectious disease physician at Rutgers at Newark, who has a clinical population of women who are just about the concentration of all the special population advantages, living with HIV, substance use, in many cases undocumented, and she's been developing ways to bring them into substance abuse treatment. So we developed a KO1 that is being reviewed this month, outstanding KO1. Several other people that we worked with on helping them develop KL2 and KO1 applications. The navigation consultations, we've really geared up this process, and they have, this is to provide technical expertise and mentorship with a particular regard usually to how do you use these enormous data sets and how do you use them appropriately? What resources are there? How do you get started? We help people with some preliminary analysis so they can determine cell sizes and feasibility. But you see that the topics are very wide across all the special populations. Actually, the largest category has been aging and geriatrics, justice-involved populations, increasingly COVID-19, alcohol use disorder, and a lot on health equity and racial ethnic disparities. So we put together this table that cross-tabulates the for our navigation consultations, the units that people are from across the top, and some of these outside partnerships. In some cases, they're individuals in other hubs that we're looking to develop cross-hub collaborations. In other cases, they're individuals that we're looking to develop research opportunities together that would use these resources. We just had another one yesterday with Kozali Simon, an outstanding disparities researcher at Indiana, and building a network of people that are involved in the Bloomberg initiatives. But you see, if you look at the topics on the left, elderly is very prevalent, several on youth, several on people with severe mental illness, a couple on HIV and infectious disease, emergency medicine. We've started to work with Lewis Nelson to help address some of the outcomes in people with emergency medicine. So if you count these, and these are the people, the consultations can be in one more category. 6 in the aging area, 4 in the addiction area, 4 in the mental illness area, and 6 of them involved consultations on training award development or training activities, which people have been coming to us for a lot. We have public and stakeholder involvement, where we're building these partnerships. And as I said, this kind of highlight activity lately has been trying to develop a quick turnaround assessment of what happens to people in this emergency release, where they're being released without proper, there's so many of them that they're in many cases, they're not getting their Medicaid cards. They're not getting properly linked to substance abuse treatment. In some cases, even individuals who had been receiving substance abuse treatment like buprenorphine in prison. We've identified some problems. They're being given prescriptions that are too low a dosage of buprenorphine, which causes them to relapse. So there's a lot of work back and forth with the clinical experts at Rutgers and the state people. We developed testimony on proposed legislation and expanding harm reduction services based on what we were seeing with the partners we brought together. And there was actually a symposium that had more than 200 participants registered, where we partnered with the Center for State Health Policy to bring together state leaders and treatment system leaders on COVID-19 impact on substance abuse treatment. It was a fantastic panel discussion. Projects that were moving forward. We were able to work with to get from the workforce development an intern to develop marketing materials for the services provided by the Special Populations Corps. We are doing a stakeholder engagement with Camden Coalition, a very wonderful project to develop a shared vision of what a more integrated care model for New Jersey would look like for multiply diagnosed people, complex patients like the ones that Camden Coalition specializes in, that typically will have mental illness issues and substance use issues and are high utilizers. We're developing a workshop on these linked Medicare data. And I was thinking a little bit, just to wrap up, about some of the evidence that we're putting together on impact. And so the whole metrics issue, I think, is becoming a little bit clearer to us as we see the actual impact in terms, for example, of K award applications that are submitted and funded, in terms of grants that emerge from this. So we do a consultation that proves the feasibility or does some preliminary analysis, and then it turns into a funded RR1. The impact on the healthcare systems impact that we can measure, and increasingly these just fabulous trainees that we are attracting, who then in turn are actually contributing, not just as trainees, but actually contributing, as Kiana, for example, has done, to moving forward the whole enterprise at Rutgers. So I thought Kiana just briefed us yesterday, our team, on the work that she's done with Mark on the UO1 application, and that was such a wonderful example of how the trainees are growing into these leadership roles. And I think Jennifer Miles is moving in that direction. Stephanie is. So that's our quick summary, and we welcome any questions.
I think, we're running just on time or slightly less, Steve. Great job. I mean, there's a lot of service. I think what we can see this year compared to other years is how we've integrated with trainees, both T's and K's, to really move this forward. We're certainly more diverse, actually, in our platforms and disease states. So I applaud that to the whole team. A lot of the geospatial localization of COVID. When I tip my hat to Panos, he was very instrumental in the RADx Up grant for that. So real progress. Congratulations, Steve and team. I'd like to move forward. And I think Cindy Blitz had a lot of comments, which we can come back to. And Bob, I appreciate your comment, feeling that Special Pops is innovative. All right, Arnold and team, are you ready? Tell us how you spent $600,000.
Happy to do that. I think we need to change screen sharing though.
Yep.
So
So I need to stop my
you need to
share. Right?
unshare.
There we
Thank
go.
you. Very good. Thank you very much, Steve. So now let me share. Let's see, where am I going here? Okay, and PowerPoint. Here we go. Share. Okay, are you now seeing mine? And I now
We
have
are.
to go to, here we go. Okay, so thank you very much. It's a pleasure to be here and to hear this really interesting discussion. And I thank Dr. Taylor. I will mention as we go on through this little talk a couple of times, because some of the points that you made resonate extremely well with our thoughts and our hopeful future directions. First, I just want to note that I'm really privileged to be co-leader with several really outstanding scientists and really perceptive individuals who've been a pleasure to work with in this core, particularly Sam Wong at Princeton. Reggie Cardill has been with us for the first 2 years from NJIT, from the School of Management, and has really guided the process in a lot of compelling ways. And Grace Wong is now joining us, Associate Dean for Research from College of Computing at NJIT. We function in coordination with an entity called the Pilot Program Management Committee. And for those of you who've had sort of interactions with NIH, for example, around cancer centers, et cetera, this would function in a sense as the parent committee for our grant application process, whereby there are reviews of particular applications by both external and internal reviewers, and then a synthesis of those reviews and often a sort of third look from another perspective by members of the parent committee who've really been very dedicated to making this process work well. The members of the committee span multiple different disciplines, as is needed in a setting like this where the applications span many disciplines, and they come from Rutgers, from Princeton, and from NJIT. And we're continuing to get feedback from them at the end of each round in terms of what can we do better, how can we engage them better, etc. So we're very grateful for the effort and the dedicated work that they've put in. The aims of the pilot program, above all, are to advance team research to promote novel approaches and methodologies in translational medicine and science. So obvious, but clearly a major, what we really are all about. More specifically, fostering interdisciplinary research that in cases leverages in-kind partner support. We'll talk about that in a few moments, to generate and test new hypotheses. I'll skip down and just note that we've also had mechanisms to really inspire new methodologies, to evaluate and assess the hub processes to improve outcomes. And this would be in conjunction with other CTSA hubs too, as you'll see. And finally, a major sort of focus has been to use these pilot activities to seed collaborations and interactions across the partners, such that, as you'll see in a moment, we require partners for send all but one of the different mechanisms we have. We require partners, PIs from our partner institutions. So let me make that very clear. Our 3 partner institutions, Princeton, Rutgers, and NJIT. And for example, the Translational and Clinical Sciences Award, our major pilot award, requires a partnership from at least PIs from at least 2 or more NJACS institutions. The Translational and Clinical Science Awards for year 1 were $60,000 each, but through the generous grant from the New Jersey Health Foundation that Ray mentioned, in year 2, we were able to bump that up significantly to $110,000 per award, which has made a difference, I think, in the intensity and focus which applicants put into the process. The second, we estimated 3. You'll see that in fact we've given 4 of these awards on occasion. We have had a second mechanism, methodologic and infrastructure awards, again requiring collaborations. A mechanism called Propel Awards, which are sort of like a mini R21, sort of high risk, high potential gain, get a project started kind of award, again requiring collaborations. Preferring collaborations. And the Valued Partnership Award, which again, we were able to bump up the award, which involves a partnership between a PI within NJ Acts and a second entity, industry, government, community, insurance, or other CTSA hubs to move science forward. And the partner is providing often in-kind support as opposed to strict dollar support, databases, the ability to do particular experiments, the materials, instrumentation, etc. And finally, this novel approaches to evaluation and benchmarking of CTSA hubs. So how have we done over the 2 years? And I'll summarize both years. Well, first of all, as you can see, we've had a fairly high overall success rate. So if you publicize this, we anticipate that that success rate will go down as more and more people apply. But that would be a good thing to have happen. In both years, we've awarded 4 of the clinical translational and clinical sciences awards. And as you see, we've had PIs from all of the partner institutions for those awards. Our applications have been roughly stable in terms of the numbers. The methodologic and infrastructure awards were a highly sought mechanism in the first year, and we made 4 of these awards. And again, particularly representation from Rutgers and NJIT with the sort of methodologic infrastructure pieces. But it was surprising to us that in this past round RFA, we only had 1 application, which was in fact funded. It was good science, but only 1 application in this. And that's something we're going to watch as we move forward. The Propel Award had this sort of high risk, high gain, had 1 each in each year, which was funded. That's been a point of discussion we'll come back to. And the Valued Partnership Award, again, 1 each in each year. So this is what we've done sort of overall. The distribution, we've had good representation by gender in both years. Note that we actually have exceeded female representation, exceeding grant application percentages in the last year. So we anticipate that this sort of representation will continue. The submissions across the different schools, I gave you the overall number, but in fact, if you look within schools, clearly the numbers are fairly small, but a number of different entities within Princeton have been represented. NGIT has been particularly represented from the College of Engineering, and not surprisingly, the medical schools, given the sort of need for sort of some of the translational aspects, have been very highly represented in the Rutgers submissions, but there's been a good set of representation across other schools at Rutgers. And this sort of principle persists as we go into year 2. There's been some engineering, but again, a lot of medical schools, NGIT particularly focused on the engineering, and again, small numbers with Princeton across different parts of Princeton. I won't go through each of the awards in the interest of time, so I want to spend a couple minutes on sort of where we're going in discussion, but we've clearly in the clinical and translational awards in the first year, and you'll see the second year hit a number of different areas, including pain and diabetes-related areas. As you'll see, a number of the awards, particularly in the first year, were sort of devices and physiatry-type related activities, and areas in antimicrobial development, again, some physiatry, recovery sorts of areas in the methodologic. And I'll note, and this speaks to what we heard earlier as well, in terms of NJIT and from Frank Sonnenberg before, a couple of awards the first year in the natural language processing area and pieces. In the year 1, a single Propel Award, as I talked about, in opioid dependence, and an interesting Valued Partner Award to look at housing and health in Trenton. And then in year 2, without spending a lot of time, but areas in sort of engineering with cardiac repair, sounds like some of the things that you might be interested in from Emory as well, depression, neuroscience with Princeton and Rutgers. This is actually quite topical, looking at a wild mouse, wilding of mice, which have different immune responses than laboratory mice in lung defense. So this is very topical now, and I don't know if they're moving in that direction. Interesting multidisciplinary look at transgender issues in healthcare, microfluidics technologies and the methodologic, and the CTSA Hub website, so novel approaches around the different CTSA Hub websites and how to sort of search across them with Barbara Tafuto, whose name you've also heard, Propel in a medical image perception, and then in this last year, the valued partnership around sort of the old Arrowsmith approach of bacteriophage formulations in conjunction for lung therapy of lung infections, actually. So this is a very interesting application. I want to spend just a couple minutes, as I think it's very important, talking about our goals overall, obviously responding to the needs of the community and providing efficient, fair, and helpful reviews. And as I think we're all facing as we think about renewal, the critical importance of maximizing the conversion of these pilots into publications and in particular NIH grants. So that is something looming in the back of our awareness as we look at how likely grants are to succeed. Importantly, we've had a lot of discussion since the last round, looking at our procedures, thinking about what can we do better. And among other points, we're thinking about, and we are going to now have a letter of intent prior to submission. And the idea of the letter of intent is, most importantly, to help us begin to generate and identify potential reviewers, because the reviewer pool has been a source of some, what's the right word, some consternation, some angst to make sure that we're getting the right reviewers. So giving us a heads up on that. Looking towards potential pre-submission workshops, potentially similar to some of the things Dr. Taylor talked about. Another issue has been the categories. And as I showed you, the Propel category with one application each time, we're not sure that people find the $20,000 compelling enough to actually start to write applications. So that will probably be phased out or not be carried forward. But in particular, we've had a lot of comments, and I'll appreciate comments from people, and again, potentially Dr. Taylor, about the idea of a targeted RFA versus our more general open-ended RFA, which we've opted for, particularly since we're new, with the idea of we want to pick grants that are going to succeed at the next level of NIH and not